Good afternoon, everyone, and welcome to our session of training for implementing medication-assisted treatment in recovery residences in Pennsylvania. My name is Jenna Nesbitt, and I am a recovery specialist at C4 Innovations, formerly known as Center for Social Innovation. This event is brought to you by the Substance Abuse and Mental Health Services Administration's Opioid Response Network and Pennsylvania Alliance for Recovery Residences. The Opioid Response Network is a consortium of partners dedicated to increasing access to prevention, intervention, treatment, and recovery support. We achieve this work through a variety of mechanisms, including technical assistance that is focused on system transformation and developing the capacity of peer-run, recovery community, family, and youth-led organizations. I am pleased to introduce today's presenter, Jennifer Ria, who is a recovery specialist with the Opioid Response Network. Jennifer will be talking about operations as they pertain to implementing medication-assisted recovery in recovery housing. I will be turning things over to her shortly, but first I'd like to review a few housekeeping items. Please remember to mute your computer microphone and speakers if you are calling in from a phone. The computer speakers can be muted by clicking on the green horn in the upper left-hand corner just above the presenter's pictures. While we are engaging today, if you have any questions during the presentation, you can use the chat and questions box located in the bottom left corner. If we have time at the end of this session, we will answer questions. Any remaining questions will be answered at the beginning of the next session if we run out of time today. We do anticipate that this will be a very full hour of content. We also have some resources for this webinar available for download from our webinar resources box. To download a file, click on the name of the document, then click Download File. Also, we will have a survey link available for you at the end of today's webinar. Please let us know how we did, as this helps us with creating better trainings for everyone. Just a reminder that this event is being recorded, and the recording link will be shared with all registrants after the event. You'll be able to review the chat and rewatch the presenters using that link. So without further ado, I present to you Jennifer Ria.
Thanks, Jenna. I'm happy to be here today, and thank you everyone for joining us. So some of the things that we wanted to spend some time focusing on today include medication security, staffing, training for staff and residents, securing records, communicating with treatment providers, and how to handle drug screening. So as Jenna said, what we're wanting to focus on is how to accommodate and integrate residents who are in medication-assisted recovery into recovery residences generally and at large. So the first topic that we're going to focus on today is medication security. So the first point is we do want to recognize that people who are in different kinds of medication-assisted recovery are going to have different medication storage needs. So some of this might be a review for you, but first off, Vivitrol and naltrexone injections, those are injections that the resident would have every 28 to 30 days in the prescriber's office. They will generally have no medications that they need to store. The injection is stored there, they get the injection there, nothing comes home with them. Now, methadone, they will typically get their methadone doses at the treatment provider clinic. However, if the resident has been on methadone for a considerable period of time, or if the clinic does not do weekend or holiday dosing, they may receive what are called take-homes. And so what this means is that they're given small bottles with a measured daily dose of methadone in it for them to take for a specific number of days before they have to return to the treatment clinic to get their additional doses. So these should be dispensed from the treatment provider in a locked box directly from the clinic to the resident. The resident should then arrive back at the residence with their take-home doses still locked in the lockbox, and they should immediately put their lockbox in wherever you have identified as the designated secure location. But again, for the most part, people who are on methadone are going to go to the opioid treatment provider clinic and get their doses each day there. Now, the one that is going to have the most storage needs is buprenorphine products, or Suboxone as an example. So these residents are going to have pills or films, and typically they're going to have daily doses that they need to store someplace in the residence. So our first question for today is around securing medications. So this is kind of a little quiz, if you will. So you can either guess or say if you think you already know the answer. In a recovery house, why are keyless entry safes or lock boxes better for medication storage than options with keys? You can select all that apply. Are they cheaper, more pretty? They're more secure since they won't accidentally leave the key around the house, or they won't take the key with them when they move.
So far, Jennifer, we have a few guesses coming in, or a few answers coming in, and they seem to be pretty evenly divided between accidentally leaving the key available or the resident not accidentally taking the key with them when they leave. So far, access through an unsecured key seems to be the primary answer, with the resident retaining the key upon exit as a secondary answer.
All right, well, you are all correct. The right answer, or most right answers, are C and D. I don't know, you might actually find them more attractive, but that is not one of the reasons why we would want to recommend that. So what we do want to recommend is that a keyless entry safe or lockbox is provided for the resident to be able to keep their medications in a centralized, secure location. Obviously, the resident is going to need to know what is the code or the combination for the box or the safe. But then another note, you do also want to make sure that either a paid staff person, or if the residence doesn't have any paid staff people, the owner or operator also either knows the combination or knows how to reset it, so that if the resident leaves, when the resident leaves, you're able to reset the box and be able to use it for the next person who would need to use it. So another piece of medication security that we want to talk about is how we interact with the pharmacy. So in some cases, a treatment provider, such as a case manager, might be available to accompany the resident to go pick up their prescriptions. And again, like we talked about before, if they're picking up a prescription, it's typically going to be a buprenorphine product. So a case manager might be available to help them go do that, get the prescription filled, bring it back to the resident. If that's not an option, then best practice would be to have a paid staff person from the residence go with them to get the prescription. And we do recognize that that might not be feasible depending on your staffing. But the next piece, which is equally important, is we want to have, we want to use pharmacies that are able to dispense medications in either blister packaging or some sort of daily dose packaging that makes it clear whether or not the dose has been taken or been tampered with, and you can visually see with pretty quickly or with pretty good ease whether or not the right amount of medications are left still for the rest of the month. And so there's an example here to the right of what blister packaging looks like. So you would be able to see, for example, if it was the third day of the month, then, and the prescription was filled on the first, then 3 days worth of medication should be gone. And so our next question here, and this one is not really a quiz so much as an opinion or some based off of your own experience, is which option do you consider better, using a medication monitoring log for all medications that a resident would take regularly, or only for controlled substances that residents take regularly? And we're going to talk about medication monitoring logs and medication lists here in a second. We'll
So
give it a
Jennifer,
couple of
so
minutes.
far, the leading response is for all medications that are taken regularly, which seems like a pretty good practice.
And that's interesting because it certainly is more work to do a medication monitoring log for all medications.
Agreed. Love that the providers on the line consider more work to be a better practice. It certainly seems that it would reduce any sort of liability as well.
So let's talk a little bit about medication lists and then medication monitoring logs. So first off, we want to say that all residents who are in medication-assisted recovery and residents who are not in medication-assisted recovery should have a complete medication list. So that includes over-the-counter, prescribed medications, controlled substances, non-controlled substances, medications that have to be locked up, and then if you allow them to keep things like acetaminophen or ibuprofen with them, all of that. Everything should be on their medication list. And we want to make sure that those lists are updated regularly. So ideally, you would have some sort of interval where you would say, okay, once a month, every resident needs to review their list, make sure everything's on it, make sure that it's up to date. But at a minimum, we want to have a practice or a policy that says any new medications that are brought in, there's absolutely a requirement that it get added to the list. Now that is separate and different then from a medication monitoring log. And so with a medication monitoring log, that is going to be a form or a log that is specific to just one medication. So you would have a sheet that is, let's say, buprenorphine specific. So it would have the resident's name, the date, what medication, what dosage, and how many or how much of it is being brought into the house today. And so if there are 30 pills, then on the log, what you're going to make sure happens is that every day they indicate that they took it, what time, and how many should be remaining. And so if it were that they came into the house with 30 pills, the first time that they take one, they're going to fill it out, the time they took it, what they took, and now there should be 29. And then the next day, if it's a daily thing, it should go down to 28, 27, 26. And so it counts down how much of this particular controlled substance should still be here in the house. And so that's another reason why the blister packs or the daily dose packs are much more convenient, because you can visually easily see is what's still remaining in this particular pack matching what this log says should still be remaining. And so if possible, what you want to have happen is if you have staff available to do medication reconciliation, then once a week or once a month, whatever's going to work for your house, they're actually doing that. They're looking at, okay, Johnny resident's medication monitoring log says that he should have 17 pills left, and I can see right here, yes, he still has exactly 17. Okay, that's been reconciled. Let me look at the next one. And so for controlled substances, we absolutely do recommend that there is some sort of medication monitoring log and, if possible, regular medication reconciliation. Now, that is a lot of work to be able to do for all medications that a person might bring into the house. So if they have diabetes medication or if they have an over-the-counter medication that they're taking, you may not be able to do that level of reconciliation and monitoring for all medications. But for the ones specific to medication-assisted treatment and any other controlled substances that might be in the house, you absolutely do want to make sure you have these much stricter protocols and stricter practices around knowing exactly what's there and reconciling that what is supposed to be there is actually still there. And so whoever is doing the reconciliation, one other note, you do want to make sure that they are signing or initialing that they did the reconciliation and everything was present. If for some reason things don't match, then you want to make sure and follow up on that, make sure to look into that and figure out what happened, what went wrong, is something being diverted, or somehow the records are wrong. But you definitely want to follow up on anything that doesn't match up exactly. So our next question is, do you have staff who would be available to monitor self-administration of medication, and do you have staff who would be available to do reconciliation? And so is the answer yes to both, no to both, or do you have staff who could do one or the other, but not both? And so we'll give it a couple of minutes to kind of see where people are right now.
We just want to remind everyone this is one of those types of questions where you just pick one as opposed to any and all. And we see some answers coming in pretty evenly split thus far among the top three choices. Oh, there is one that just came, there are a couple more that just came in. So far it looks like no to both is in the lead, with some yes to both, can monitor reconciliation, or can monitor medication but cannot reconcile, and then can reconcile but cannot monitor. And I would imagine that would be a distribution of diverse capabilities based on the structure of each recovery house staffing pattern.
Absolutely. And so let's talk specifically about observation then. So if possible, you would want to require staff to monitor residents when they were accessing their medication, when they would take their medication, and then for a short period of time immediately following the self-administration of their medication. And so we do recognize that this may only be practical in a level 3 or higher. However, it might be possible for a level 2 residents to specifically schedule their paid staff's working hours to coincide with the time that residents typically take their medication. And in order to accommodate that, you may want to have a scheduled specific time of the day for when people take their medication. Obviously, that might not be feasible if someone has been prescribed to specifically take their medication morning and night or at noon. And so you might not be able to accommodate having a staff person present for all of the different scenarios that your residents may have. Now, the reason for having staff monitor the resident for several minutes or for a short period of time after they take it is to make sure that there's no intention of diversion. So making sure they're not hiding it in their cheek or putting it in their pocket or something like that. So if possible, you're wanting to make sure that someone is there when they're accessing it, someone's there when they're taking it, and that someone is there with them for a couple of minutes afterwards. And then if you are using staff to monitor self-administration, then you want to make sure that that staff person is signing or initialing that they're the person who did that observation. So the next question that we wanted to ask about is whether or not you have naloxone in your recovery residence. And so if you are able to weigh in on whether or not you already have it or you're planning to have it soon, that would also help us, because we wanted to talk a little bit about how storing naloxone is different from storing the other medication-assisted treatments.
So far, it's looking pretty good. Everybody seems to be prepared with naloxone. And I just want to encourage you, if you are an owner-operator and you don't have it, it's okay to answer honestly. This has just been a learning curve for everybody in the recovery resident space with regard to responding to opioids. So if you don't have it, we can certainly try to follow up with you on your state's programs for obtaining naloxone through the opioid responsive grants that they have.
All right, so far it looks like everyone is indicating that they do have naloxone in their recovery residence. So we wanted to talk about how that should be stored as well. So what we recommend is that naloxone is stored in the same location as where you store residence medication. However, the naloxone should not be locked up. So the residence medications are locked up, naloxone is not. What you want to make sure of is that it's available for immediate access in the case of an overdose. However, if you allow family visits to your recovery residence, you do want to make sure that the naloxone is stored in such a way that it's out of the reach of children or out of the reach of someone who shouldn't be able to access it. You absolutely want to make sure that all residents and all staff get training in how to administer naloxone. And then with that comes, if you happen to change the type of naloxone that you stock, so if you had an injection or an automated injector and now you have a nasal spray or vice versa, you want to make sure that staff and residents get retrained in how to administer and use the new product. So just something to keep in mind if that changes or if your state changes which type of product they make available. And so I want to talk spend some time talking about staffing competencies and staff training. So one of the first things, as we mentioned previously, is to try, if possible, to schedule staff to be available to monitor self-administration of medication. And when staff observation is the standard protocol for a residence, the staff person does typically keep a key to either a locked room or a cabinet where all of the lock boxes or individual safes are located. And in those cases, residents are able to access their safe or their lockbox when the staff unlocks the room or the cabinet. And this is advisable in a level 3 recovery residence or a residence that has regularly scheduled staff. If this residence does not have regularly scheduled staff, then obviously you wouldn't be able to keep the room or the cabinet locked, but each individual resident's box or safe is locked. In some residences where staff observation of self-administration is the normal protocol, but a particular resident is prescribed to take medications outside of the times when staff will be available, that resident might be permitted to keep the specific dose or doses on their own person to be able to self-administer it on their own. However, this should be an exception. It should not be the standard practice for residents to carry MAT medications around with them throughout the day. If your house does do this and you're keeping records regarding the residents' particular medications and their medication monitoring logs, you definitely want to make a note if a medication was carried with them for them to take, a couple of hours later or something like that because of an exception. You want to make sure that that's documented and that that's part of the record. When we're thinking about how to train staff, one of the first things we want to make sure of is that they are knowledgeable about policies and procedures for managing on-site medications. We want to make sure that we have practices around requiring them to sign for receipt and understanding of the policies pertaining to medication security. And then we also want to make sure that staff understand the difference of what is dispensing medication or what is giving medication versus observing someone self-administering. And so what we want to make sure of is that they understand that they are not dispensing or administering. They are simply observing the resident self-administering. So this means that staff should not take medications out of the original package and put it into like a pill box for the client. They should not take the medication out of the original package and put it in the client's hand or in their mouth. They should not give a resident an injection unless it's an emergency naloxone situation. And they should not tell the resident to take the medication any other way or do anything different with the medication than what is actually on the prescriber's instructions on the package. So this does mean that the resident needs to be able to read and understand their own prescription directions, either from the prescriber or the pharmacist, and they need to be able to count or measure the amount or number of medications that they are supposed to self-administer. Those are not rules for the staff person in this situation. If the staff or the resident has any questions or confusion about the dosage or the route or how to handle the medications, we always want to make sure that we recommend contacting the prescriber, do not guess, and make sure that staff are also trained to be attuned to any behavioral warning signs of inappropriate dosing or misuse of medications that might include things like drowsiness, fatigue, mood changes, an increase in drug use ideation, or disengagement with the other housemates. So we want to make sure that as we're providing staff with training, we're making sure they understand our policies, they understand what their role is not, how to monitor for symptoms, and then we also want to make sure that if we're requiring them to do urinalysis monitoring, that they understand what are the house's practices, rules, protocols, how do we do it, how do we record it, and we'll talk a little bit more about that later, but we want to make sure that everyone in the house is trained on exactly what is the expectation and how does this particular residence expect people to do it. So in addition to staff training, we also want to make sure that residents get training. And so one of the things is first making sure as soon as they move in or even before they move in that they understand what are the policies, what are the protocols, what are the expectations around MAT medications, but then also what are the policies, what are the rules and expectations about all other medications too, both over-the-counter ones and prescription ones. You may have a list of prohibited medications, and some of these might even just be over-the-counter ones like cold or flu medications that have alcohol in them or that have other substances in them that could be mood altering. So if you're prohibiting any particular medication like that, you want to make sure that residents have all of that information up front. You want to make sure that they have copies of your policies, your protocols, about exactly how their prescriptions will be handled. And again, this is all prescriptions, not just medication-assisted treatment ones. And then for individuals who are in medication-assisted recovery, you want to make sure that you do have a specific conversation to make sure that they understand how their medication is going to be stored, they understand how they're going to administer it, what kind of records are going to be kept, how their privacy is going to be maintained. You want to make sure that you have all of that information clearly laid out and clearly spelled out for the resident at the point when they move in or even before they move in. And so one of the other things that we want to make sure that we talk about is the reality is it's possible that diversion is going to happen. It's possible that there could be an overdose in the house. If the worst case scenario happens, if something happens, one of the first things we want to make sure of is that we're focusing on facts. So gathering as many facts as possible, avoiding rumors, avoiding buying into things that you don't have any factual basis for. Determine if this is a relapse. If it is, then handle it the same way that you would handle any other relapse. Any person who was living in the residence who had a relapse, what would your normal protocol be? Would it be that they need to engage in a higher level of treatment? They need to re-engage in treatment? It might be that you require them to move out and go into residential treatment for a period of time. Whatever your protocol is, for people who are in medication-assisted recovery, you're going to handle any relapse the same exact way, even if the relapse is related to the medications associated with medication-assisted treatment. Number 3 is really the same philosophy in the sense of you want to determine whether this individual who's involved is still committed to the goals and the philosophy of the residents, and are they still abiding by their resident agreement. So if you find that medications were stolen, then you want to, and you've determined that this was not a relapse, they were sold or diverted for some other reason, you want to look at, okay, does this person still meet the criteria for living in the recovery residence? And you want to handle it looking at, these are our rules, these are our policies, and this is the particular policy that the person has violated. What we really want to avoid is overreacting. And that is often a temptation when something happens. So if something bad were to happen with regard to the medications, what we don't want to do is say, okay, well, we're no longer doing medication-assisted recovery in our residents. Because the reality is you probably already have policies and rules that will reasonably respond to whatever bad scenario or whatever problem might come up. And so we want to make sure that if possible, we're not creating new rules in response to exception situations. And then the other piece is we do want to make sure that you provide opportunities for the residents, for the staff to process, because this may be a trigger for them. This may cause other concerns to arise. They really may need to have a discussion about how they feel about this, what they think about this, if this has changed their view or their perspective about other paths to recovery. So we want to make sure that we give individuals an opportunity to process and to talk about this in a safe and open, honest dialogue. And so with this whole thing, talking about open and honest dialogue, we recognize that especially for residents where they're just getting ready to start bringing in people who are in medication-assisted recovery, that this is a process. And we really want to make sure that the owners, the operators, the staff, and the residents have the opportunity to really think about this, to consider all of the implications, and to put together an intentional plan. And within the plan, we want to look at how do we prepare the residents who already live here? How do we have discussions about the changes that are coming? How do we talk to the residents about their fears and their concerns? How do we provide them with the support, options, tools? And if they really feel like they can't live here anymore, how do we link them to an environment that's going to work for them? And another sort of key point is making sure that all of the house staff are on the same page. We recognize that this can be a topic that sometimes is sensitive for people, and so we want to make sure that we're not only intentionally respectful and concerned about residents' experiences, but we're also intentionally respectful and concerned in taking into consideration staff's experiences and any concerns or fears that they may have. And so this might include having a formal process like a timeline that has meetings in it, specific training times, or individual work with residents. You might invite the residents into a participatory process where you ask them about their questions, their fears. You want to make sure that you give everyone information about medication-assisted treatment, information about medication-assisted recovery, so that's residents and staff, to make sure they have accurate facts, they truly understand addiction as a disease model and what these medications do and what they don't do. And optimally, you'll be able to engage them in an open discussion about the changes that are coming up. You'll be able to invite their input. You'll be able to give them education and give feedback about any policies or procedure changes that you're starting to implement. The more that you can ask people for their input and their opinions about those, the better their sense of safety and their sense of well-being about the changes that are coming is going to be. And so the next thing that we wanted to spend some time talking about is health information privacy and monitoring. And so one of the first things that many people are familiar with is HIPAA. And so people sort of broadly know, okay, HIPAA is the law that says my health information is protected. So we wanted to talk about how does HIPAA apply, how does it not apply, what are the things that you need to know, and what are your responsibilities with regard to health information. So first of all, like we said, HIPAA is the federal law that controls how a patient's health records can be handled, secured, and exchanged. And then additionally, 42 CFR Part 2 is the federal law that gives special protections that are even stricter than HIPAA to health records that contain substance use disorder treatment, diagnosis, and referral for substance use disorder treatment. So as a housing provider, not a healthcare provider, unless you are a level 4 house, recovery residences typically are not specifically covered by HIPAA or 42 CFR. However, because you will need to collaborate with treatment providers in order to support your residents, you might receive treatment records from them. If you get anything from a treatment provider that includes something that would identify a person as a patient of theirs, so that could be their name, their date of birth, social security number, patient ID, or if you get anything from a treatment provider that includes their diagnosis, information about their treatment or treatment that they're referred for, you need to protect that information. Your responsibility is to not allow other people to access it without consent from the resident. If the information is electronic, then you want to make sure that it's in a locked, strong password-protected computer. If it's on paper, then you want to ensure that it's in a locked filing cabinet or some other secured location. And you also want to make sure that you know that you cannot re-release information that you've received from a treatment provider to someone else. So if the resident says, oh, hey, can I have a copy of what you got from my treatment provider, you want to redirect them back to the treatment provider personally and get their own original copy. You don't want to re-release it to anybody else. Now, on the sort of flip side of that, if you have records about medications that you're keeping, so you have a medication monitoring log or something like that, and you need to share that with someone, you obviously want to make sure that you have copies so that you're not giving up your original. So since often in a recovery residence you might not have copy machines and things like that, you do want to think about how would I accommodate it if I need to share information with someone. So our next question is, have you ever experienced a time when a treatment provider would not talk to you about a resident's treatment or wasn't interested in hearing from you about concerns that you had? And so if you would weigh in with yes or no, if you've ever had that experience.
So this is a great question. Because of HIPAA and 42 CFR, it seems sometimes that providers are a little nervous about, and rightfully so, because they're federal laws, about discussing patients that they serve that you may have as residents in the home. But there definitely are some tools that we can provide you with this presentation today to equip you with being able to talk to the providers for the purpose of continuity of care, and that is a really important aspect to consider when we're talking about safety of the residents. So far, Jennifer, 3 people have responded, and 100% have said yes, that they have experienced some of these issues when it comes to continuity of care with a provider and communicating about residents.
And so to your point, Jenna, something that does come up is the fact that protected health information is defined pretty broadly. And so any information that doctors, nurses put in a medical record, conversations they have about a patient, anything that's in a health insurer's computer system, billing information that has individually specific information, all of that is considered protected. And so oftentimes, as you noted, providers, people who create the treatment records are going to be hesitant to disclose any of that information or share any of that information with anybody else outside of their particular health system. So as you said, there are some tools that can allow us to have this collaboration and this coordination. So one is what's called a business associate agreement, and then the other one is an individual consent for the release or exchange of information form. Sometimes you'll hear that referred to as a ROI, stands for release of information. And these are very different documents. So we want to talk about what is the difference between the two documents and what is the purpose of them. So with a business associate agreement, This is a document that's basically a blanket statement that says you agree to fully comply with the federal laws regarding how healthcare providers have to handle healthcare records, and you agree to be treated as if your recovery residence was a healthcare provider. Now, if you have an affiliation with a treatment provider, you may be asked to sign a business associate agreement. And what you need to know about that is that this document puts your residence under the same full laws and liabilities as the healthcare provider for the handling of the records. So this means that you must handle, store, destroy all electronic and paper health records exactly as is prescribed by law, and you can be held liable for breaches of health information if you fail to do this. So this might be perfectly acceptable to you, and if you have the means to be able to fully comply, then that's great. But we want to make sure that you understand what a business associate agreement really means and what it does. Now, the other document is an individual consent. So this is a document that says we are going to exchange information specifically about this one resident, or in the treatment provider's case, client or patient, and it's going to be limited to this specific set of information for this specific purpose, and it's for this specific period of time. And so this does also require that you handle the records confidentially, that you keep them private, but it does not put you under the umbrella of the same restrictions and responsibilities as a healthcare provider. So at a minimum, the healthcare providers that you need to work with, or the treatment providers in your community, are absolutely going to require a exchange of information form for each individual. So this is a form that the resident is going to have to sign, and they're going to have to list you or your residence, and they can just put the resident's name. And it's going to specifically say that the treatment provider can exchange information with the housing provider for the purpose of care coordination and for this specific period of time. So federal law does state that these forms do expire at minimum every 365 days. You can make them for shorter periods of time, but you will at least have to have a new one signed by the resident every year while they're staying at the recovery residence. And so at a minimum, you need to anticipate that every resident who comes in, who you need to collaborate with a treatment provider on, that resident needs to sign a release of information form with that treatment provider in order for you to be able to exchange records, in order for you to be able to get information that you need from the treatment provider. And this might seem strange, but even for you to call the treatment provider and them to acknowledge that, yes, they are a patient and I will have a conversation with you in which you're going to give me information, that form probably also needs to be signed, because otherwise they're not even going to confirm that that person is a patient. And so that's the reason why sometimes if you call and like, well, I don't want information, I just want to give information, they can't even confirm the person's a patient. So that's the reason that that form needs to be in place for information to flow either way. And so when we're talking about what information should be exchanged with providers, what information you want to make sure that you are communicating to the provider at a minimum, you want to make sure that you know when dosage changes are happening. So if the prescriber is increasing or decreasing doses, that's something that's important for you to know, because there may or may not be side effects, there might be mood changes, there might be increases or decreases in cravings. So you want to make sure that you have that information. You also want to make sure that you report any concerns about diversion, or if you know that something has been diverted or medication is missing when you did the reconciliation. You want to make sure that the prescriber knows that. You also want to make sure if somehow you come to know that this resident is getting controlled substances from multiple prescribers, you want to make sure that the prescribers know that, because it could have been an accident or it could be intentional, but you want to make sure that people know if there are multiple prescribers all prescribing controlled substances. Again, if you become aware of a relapse or some recurrence of use, that's something else you want to make sure that you're letting the prescriber know. And obviously, as the housing provider, it's certainly going to be likely that you're going to know about these things well before the prescriber knows, especially if the prescriber is seeing this person every couple of weeks or even once a month. It might be a while before they know about these things. And so to make sure that people are getting the proper care and are getting the proper coordination, you want to make sure and reach out, let the prescriber know about any of these things that you observe or any of these things that you notice. So another thing that we want to talk about is urine drug analysis. And so what we want to point out is that all recovery residences should have some sort of drug analysis process or protocol. How frequently, that's probably going to depend on the particular residence that your recovery house is serving. But we want to have policies that focus on drug analysis being regular, drug analysis being random, drug analysis being applied equally. But then we do also want to talk about specialized tests for residents who are in medication-assisted recovery. So we recommend that drug screening happens for all residents, and maybe even staff should be done on an ongoing, regular basis, not just at the time of moving in or not just at the time of hire. It should at least at some points be done randomly. You want to move around the days, times, intervals, so that it's not predictable that drug screenings always happen on Mondays at 3 o'clock. You also want to make sure that you're testing all residents equally. You do not want to be testing residents who are in medication-assisted treatment more frequently than those who are not. You don't want to say we only test people who are in medication-assisted treatment. You want to apply your policies equally across all residents. There are some affordable tests which will isolate methadone and buprenorphine away from other opioids. And so what this would allow you to do if you use a drug screening cup, kind of like the one that's on the screen, and it has instant response indicators on it, there are some tests that will actually indicate if there are opioids present that are not methadone or buprenorphine, meaning they are not prescribed ones. And so if you use tests which include screenings for methadone and Suboxone, that would allow you to determine are they taking their medication, because just the columns for the medications should light up, and it would allow you to determine are there substances present that should not be there or that are not prescribed. Now, these tests will tell you are they taking some buprenorphine or some methadone, but they will not tell you how much. So it is possible that it would be positive saying, yes, they're taking buprenorphine, but that doesn't mean that they haven't diverted some of it. Certainly, the test is just going to show you that some of it is present. So if you do have any concerns about diversion, or you've administered a drug test and it came back as other than as expected, then you would want to either communicate directly with the prescriber, let them know this is what the drug test that we administered, this was the result. When you have your treatment appointment with them, can you follow up? You may have more sophisticated testing. The other option is if you have a relationship with a actual lab confirmation partner, you could send the sample out to have further confirmation done, but that likely is not something that most recovery residences are going to have. So again, that might be something that you would want to talk to the treatment provider about facilitating having done. So our next question is whether or not your residence currently uses point-of-care testing cups that show the different substances, and then do you use point-of-care testing cups that isolate methadone and buprenorphine out from other opiates?
So just a reminder for our audience, these are two separate polling questions. And while you are all reflecting on your answers, I think it's important to note, just as Jennifer said, that any of your medication-assisted recovery residents are already going to be engaging in a drug screening process of some sort in order to be compliant with their medication-assisted treatment protocols. However, this doesn't preclude owners and operators from doing separate screenings. In fact, if anything, it can be considered possibly a check and balance when you have some inconclusive results. But as Jennifer indicated, when you have an inconclusive result, it's always a great idea to opt for another test, not with the same instrument that was used. We do know historically that sometimes a whole entire batch of urine drug screen tests may have some variability with reliability, and so opting for a different type of screening instrument is always a good example. So while I was rambling on, we did get some responses in, and on the first polling question, Jennifer, it is split 50-50 between using the point-of-care testing cups, and then also 100% said no, they are not currently using the type that will isolate methadone and buprenorphine.
All right, so that might be an opportunity for operators to consider, or something for them to just be aware of as something that is available if they feel like that would be helpful for them. So one of the last topics that we wanted to talk about this afternoon is how do we balance privacy of the resident with an environment that is characterized by peer support, self-disclosure, and how do we make sure that we have house rules that respect people's privacy, but that also encourage openness and encourage sharing and peer supportiveness. And so one of the things that we want to make sure that all residents are aware of is that there is an expectation that they treat their housemates' information the same way they're expected to treat information when they go to treatment. So residents who have been through treatment, which obviously most have, they know that when you go to groups, there's an expectation that you're not going to disclose information about what you hear about the other people who are participating. Those same standards, those same rules should apply in the house. People should know and should be aware that the information that they may know about their housemates, information about their treatment, that's confidential, that's a private thing, and that they need to respect that and they need to keep that private. However, residents also need to recognize that simply as a feature of living in a recovery residence, it is known that the people that they're working with, the people that they're serving, or the people that they're living with, they're probably going to know about the fact that they're in treatment. They're going to know about the fact that they're in recovery. And so they just need to expect that that is something that is going to be a reality, and they need to be able to balance that and accept that. And so then the next thing that we wanted to be able to talk about is with the concept of insurance. So if you are a house that previously did not allow narcotic prescriptions or controlled substances, and you're about to start accepting residents in medication-assisted recovery, it is important to update your insurance carrier. So many policy applications do ask whether or not you store controlled substances on site. And in some cases, the answer is not going to make any difference to your prices or your policy. They simply want to know what are your practices. And in other cases, they may respond saying, well, we need you to document what are your processes or your plans for maintaining security if you answer yes to that. But either way, you do want to make sure that you update the carrier if you are making a change from not allowing them to now allowing them. So as we talked about today, when we're preparing to accommodate residents who are in medication-assisted recovery, it is a process. And it's a whole sort of gamut of things to think about, including security, staffing, monitoring, how we store medications, really trying to be flexible and understand different people's needs and different people's requirements. Also setting realistic and achievable goals and timeframes for making the transition. But then even after you've implemented, continue to review your policies, your structures, any operational changes that might still be needed with the residents who are living there. You want to make sure that you're giving staff training to be able to address the needs of incoming residents who are in MAR. You want to make sure that you're looking for resources for staff and for residents to be able to deal with any conflicts that arise. If you're able to provide staff with active listening training or even conflict resolution training, that could definitely be a helpful thing, because there may be situations where residents who are in MAR and residents who are not have very strong opinions and have very strong feelings about the other person's path to recovery. And so the more that we can give people tools to have helpful, open, honest conversations, the better the environment that we're going to be able to provide for everybody. So as we're coming to the end of the hour, we did want to give some time for questions today. If anyone has any questions that they would like to enter into the box, we do have a couple of minutes here still.
Jennifer, I wanted to say that you've done a great job. We do have some individuals starting to type some questions, and while we wait for the questions to come through, I just wanted to point out that this is a lot of content to have to take in. So we do encourage you to go back and review the recorded version, since we talked about so many different logistics today. Yes, so we have a question that says, are we able to have a copy of the PowerPoint presentation? You will be able to access the webinar itself through our link to the recording of the webinar. And then we have another question coming in. While we're waiting for those questions to come in, we did want to thank you for joining us today. I also want to make sure that our moderator, Vanessa, knows that we are very thankful for her ensuring that we stay on track, the presentation runs smoothly. She is the one who's been able to pop up the poll questions and then return us back to the chat box, and it takes a little bit of coordination on her part. So I'm not seeing any further questions come in. Please remember that you can request technical assistance from the Opioid Response Network at any time. We will have that link for you in the box, but in the meantime, you can simply go on over to the Opioid Response Network website at opioidresponsenetwork.org, and you'll see Submit a Request in the upper right-hand corner. We also want to remind you that there is a short survey that will pop up when we conclude. Thank you, Vanessa. I want to point out that the link is right there in the chat box for those of you who are interested in submitting a TA request. We do encourage you to fill out the survey that tells us how we did, or if there's any other things you want to know about. This helps us fine-tune our work, not only to benefit you, but to benefit other TA requesters that are reaching out across the nation to talk about implementing medication-assisted recovery proficient accommodations in recovery residences. Some of you may be familiar with the federal funding for the opioid response, but the latest batch of funding that's come down from the feds does require that the states implement some type of recovery housing that supports people on opioids. So we do anticipate that more individuals and houses, owners and operators will be coming forward to seek assistance with how to do that. Once again, we do want to thank you for joining us. We really are just about at time. So any questions that you may have, you can certainly send them to Fred Way, and he can make sure that we answer those questions for our 5th session, which will be in 2 weeks, where I will be presenting and talking about stigma in recovery residences, which is definitely a topic that we do have to delve into as we move forward. So once again, we do thank you for joining us, and we hope you have a wonderful day.